Hi guys, welcome back. You're aware of Guillain-Barré syndrome, which is an autoimmune disorder characterized by demyelination of the spinal cord and the peripheral nerves. In this video, I'm going to talk about multiple sclerosis, which is again autoimmune demyelination, but the target would be the brain and the spinal cord. And the common thing between the two is obviously demyelination, and GBS is going to be lower motor neuron lesion, whereas multiple sclerosis is going to be because of involvement of the brain, upper motor neuron lesion. But what is the fundamental difference between the two from pathological perspective is that autoimmunity is common between the two again, but the difference between the two would be that the antibodies which are derived here or present here for the demyelination are locally synthesized in the brain and the spinal cord. In contrast, in GBS, where the antibodies are peripherally synthesized, what I mean by peripheral is in the lymphoid organs, here the B cells and the plasma cells of the brain and the spinal cord are attacking self. They are attacking the myelin basic protein, and therefore the pathological hallmark of this condition would be a development of perivenous demyelination. I mean the characteristic word, because demyelination you're gonna read in multiple disorders, but nowhere are you gonna read this particular word that I've written at the moment, perivenous demyelination. And the same perivenous demyelination is also visible on the imaging modality of choice for this condition, that is a MRI. We usually do a gadolinium based MRI or gadolinium enhanced MRI for diagnosis of this condition. And you will hear the radiologist talking about Dawson fingers. They would be white lesions which would be perpendicularly arranged to the ventricular surface. I'll show the image of the same subsequently, but I'm trying to just correlate here the clinical information at the moment with radiology, which is perivenous demyelination, a hallmark of this condition, will be responsible for the radiological finding of Dawson fingers. Now, because of the fact that the myelin covering in this particular case is affected, and the myelin will basically be giving trophic support to the axons, so the axons will be exposed. Therefore, the second thing that will happen in this condition is a axonal damage, and this axonal damage will explain the development of conduction block. See, on the axons we have potassium channels. Because the axon is exposed, the covering is gone, so there would be repeated stimulation contributing to hyperpolarization of the axons, and the hyperpolarization would mean that the axons will fail to fire, and therefore you read about conduction block in this condition as well. On electrodiagnostic studies, the axonal damage in this condition shows up in the form of a conduction block. This conduction block is also variable and is affected by body temperature. What I mean by affected by body temperature is on increase of body temperature, the conduction block worsens, and therefore neurological features in this condition worsen on heat exposure. When I say that, most people say, wait a minute, really? What did you say? You mean neurological symptoms in a patient are developing / worsening on heat exposure and are worsening on increase of body temperature? Yes, guys, I'm describing a very peculiar manifestation of this condition called as Utov phenomenon / Utov symptoms. This Utov symptom or Utov phenomenon was initially described in Russian females, white female who was suffering from multiple sclerosis, where her neurological symptoms were worsening / developing on heat exposure. Like this lady who was physically very active, used to regularly go and work out in a gym, says that for a couple of months, every time I work out in a gym, I tend to get a lot of cramps. Now, what is cramps for her is actually spasticity that is developing in her hamstrings, which is preventing her from doing a regular workout. Her coach is thinking she's prone to getting these muscle cramps, but from a doctor's perspective, you'll be able to pick up Babinski sign, you'll be able to pick up extensor plantars, because there is demyelination occurring for the corticospinal pathway in this condition, which explains the development of these spasticity manifesting as muscle cramps in these patients. In fact, the symptoms of these patients will worsen on heat exposure. Like if this patient takes a hot shower, or like takes a steam bath, sauna bath, or does extensive workout, or there's fever in a patient, then the symptoms will tend to increase. And that's the pathological correlate that the conduction block in multiple sclerosis has been shown to worsen on heat exposure, which gives credibility to why we read about Utov phenomenon in these patients. See, in hyperthyroidism, you read the term heat intolerance, but here I'm not talking about any heat intolerance. Like I'm not saying that patient is not able to tolerate heat. It is neurological symptoms which are developing on heat exposure, which is very peculiar. Before I go to point number 3, I want to highlight two important points that I've highlighted in the first few minutes of this video. One is CSF electrophoresis will be given in the workup of the MCQ of this condition. So even if you're not able to remember the entire clinical profile that I'll describe for this topic, you still can crack the question on the word CSF electrophoresis showing presence of oligoclonal bands. Another hint would be symptoms worsening on heat exposure, that's written as Utov phenomenon. Now let's look at the third manifestation, because substantial amount of damage has occurred. So the repair system of the brain will step in, and the repair system would be composed of oligodendrocytes. Now let's look at what the oligodendrocytes would be doing in this case. These oligodendrocytes will now be responsible for the remyelination of the axons, and as a result of this remyelination of axons, the finding that we encounter is referred to as shadow plaques. So every time when you listen to a radiologist talking about multiple sclerosis, they'll always use these terms like Dawson fingers or plaques visible on an MRI. And gadolinium enhanced MRI is what we prefer in this condition, because we want to prove the damage to the blood-brain barrier. Now the astrocytes will also step in this case, and therefore what you will have in this case would be an astrocytic fibrosis. For pathology, we don't use the word fibrosis. For the brain per se, we use the word gliosis. So the astrocytic proliferation in this condition will explain why do we read about astrocytic gliosis in these patients as well. So there are four pathological manifestations that I've described for this topic. Perivenous demyelination, that is Dawson fingers; axonal damage, which is worsened on heat, or the manifestations of axonal damage which are worsened on heat exposure; the remyelination showing up as plaques and astrocytic gliosis / fibrosis in the brain. And the same can be seen on this line diagram as well, where there's a demyelination that has been shown by me here, and the attack is against myelin basic protein by autoreactive T cells as well as B cells. Majority of the antibody which is present in multiple sclerosis is locally synthesized in the brain and the spinal cord, and these autoreactive T cells are causing this damage. Therefore, because we know that these autoreactive T cells will cause a damage, to tame them, to control them so that they do not cause further worsening of the patient, to prevent repeated attacks of neurological symptoms developing in these patients, to control this misbehaving autoreactive T cells attacking against myelin basic protein, we have a monoclonal antibody by the name of natalizumab, which again has an alphabet T, by which you can remember that this antibody, what it will do is it will bind to this integrin. Integrin is the cell adhesion molecule by which the T cell will be causing damage to the blood-brain barrier, and as a result of it, the manifestation would be in the form of prevention of secondary attacks. In fact, this is the most effective drug. We'll talk about the pharmacology of multiple sclerosis management in a while, but the commonest variety, the relapsing variety of multiple sclerosis, where we have multiple bouts present, one of the most effective drugs that we use is natalizumab infusions. Nowadays, we have monoclonal antibodies which can be given at home as well, subcutaneously by the patient on a monthly basis, but the one that is initially introduced and was given monthly as an infusion and still given at the moment is natalizumab. Similarly, we have problem with B cells as well, and these B cells would be having CD20 molecule. The mature B cells, which are the troublemaker in this case, are the ones which would be expressing CD20. So we have an anti-CD20 molecule. The famous anti-CD20 molecule that everybody knows is rituximab, which can be used in this condition as well. But another one that I am discussing at the moment, a highly effective treatment for relapsing variety of multiple sclerosis, is ocrelizumab. This would be anti-CD20 molecule, and CD20 is expressed on mature B cells. Now CD20 is present on mature B cells, so if I have a molecule which is against anti-CD20, it will deplete those mature B cells which are the villains which are causing damage to the myelin basic protein. But because only the mature B cells are getting removed, it will not have a significant impact on the humoral immunity of a patient. So we will talk about the pharmacology of these drugs more in detail as we progress, including the side effects as well. But in the initial two slides, I've tried to highlight with respect to the pathophysiology of the disease and correlate it with radiology. Two important findings I mentioned was Dawson fingers and the development of plaques. And the second thing what I highlighted was the use of monoclonal antibodies for the common varieties of multiple sclerosis. And the two common varieties of multiple sclerosis that we come across are relapsing. Initially, it was called as relapsing remitting multiple sclerosis. Nowadays, the term used is only RMS, that is relapsing multiple sclerosis. 90% of cases would be relapsing variety. Relapsing variety would imply that neurological symptoms would come and go. Like this lady, she says, "Doctor, it's embarrassing to say, but for past couple of days, I was sleeping and I passed urine in the bed. There was urinary incontinence developing in this lady." Then she says, "I was okay for a couple of months. And then I started having these cramps in my legs, because of which I was not able to going about my daily regular workout in a gym." And then she started having visual blurring and the symptom is decreasing. And a new symptom is coming up. So this condition will be causing selectively or more commonly white matter involvement. It would be non-contiguous areas of white matter that will be involved. But what you will notice in these patients is that attacks would occur, then asymptomatic period, then again a new attack would be coming. So relapsing variety of multiple sclerosis is the most common variety, and the least common variety of this would be primary progressive multiple sclerosis. The primary progressive multiple sclerosis would be in 10% of cases, and the approach to both of them is slightly also different. For the progressive variety of multiple sclerosis, one of the main weapons that we use is ocrelizumab. We can use it in relapsing variety also, but specifically because it was a recent question, what drug is used for primary progressive multiple sclerosis? Why that is important is, in the older version, you will notice in 3.0, you will notice that I said that there is no treatment for primary progressive. In 4.0, I said ocrelizumab is being tried for management of this patient, but now it has been documented to be highly effective. So for primary progressive multiple sclerosis, ocrelizumab has been shown to produce significant improvement in the clinical burden of the disease. It also reduces the attack rate. The monoclonal antibodies are the main weapon of offense, as I said, for management of this condition, and I mean, it has been proved in randomized controlled trials, and ocrelizumab is one of the drug of choice for primary progressive multiple sclerosis. Now, the manifestations in this condition will be occurring at different times. Why that's important for us to demonstrate is because the non-contiguous areas of the brain are getting involved at different times. So if the lesions are occurring over different areas of the brain, then we use words like dissemination in space. On the other hand, if they're occurring at different times, like I was saying, in January, she had urinary incontinence. Then in February, she was okay. Then March, she started having spasticity in her legs and she stopped going to her gym. And then optic neuritis came in, though optic neuritis is one of the commonest manifestations of the disease. But just for examples, like what I've tried to explain in this condition is symptoms are coming and they're going, and they are occurring at different time zones and at the same time in different areas of the brain. That is why terms like dissemination in time and dissemination in space is used. From the race perspective, you would be aware that this disease is more common in whites, unlike in neuromyelitis optica, which is more common in patients of Asian or African descent. We will notice multiple sclerosis is more common in whites. Gender-wise, obviously, all autoimmune disorders are more common in women as compared to males, and the usual age of presentation will be between 20 to 40 years of age. In fact, from the exam perspective, you guys should be clear regarding the keywords that are to be picked up in an MCQ for the three disorders: multiple sclerosis versus neuromyelitis optica spectrum disorder versus MOGAD. MOGAD would mean that there's a special antibody that is present, that is myelin oligodendrocyte glycoprotein antibody. For multiple sclerosis, most of the time in multiple choice question, he'll be describing a female. She'll mostly be a white female, and the major complaints of this patient would be that of optic neuritis, which would be described in the question as unilateral decrease in visual acuity, or the central vision of this patient is getting hampered, or the color vision of this patient would be hampered. And usually the question will not begin by describing blindness. But if you read about a question of a patient who is of Asian or African descent and then says that this lady is having a bilateral optic neuritis which is causing development of blindness, we need to think in terms of neuromyelitis optica spectrum disorder. Another highlight of this disorder would be involvement of spinal cord, which would be longitudinally extensive transverse myelitis, LETM. So if you read about Asian descent and you have bilateral optic neuritis with longitudinally extensive transverse myelitis, see, spinal cord can be involved in multiple sclerosis also, but it is not usually seen or is not a very common manifestation. But in neuromyelitis optica spectrum disorder, it will always be given in the MCQ: spinal cord involvement, and longitudinally extensive would mean at least 3 contiguous spinal cord involvements present. And to help you, he will also mention about an antibody by the name of anti-aquaporin 4 antibody. Now suppose you get a question in which he is talking about bilateral optic neuritis. He is also describing longitudinally extensive transverse myelitis, but specifically he mentions that the part of the spinal cord that is involved in this condition is demonstrated to be conus medullaris, and along with that there is a presence of a special antibody. See, the antibody which was present superiorly was anti-aquaporin 4 antibody, but now the antibody name is anti-myelin oligodendrocyte glycoprotein, MOG antibody. So we call it a MOGAD. So MOGAD would be myelin oligodendrocyte glycoprotein antibody associated demyelination. Guys, these 3 disorders are having a demyelination. I think it will be easiest for you in an MCQ to pick up multiple sclerosis because it will have a unilateral involvement. A spinal cord involvement may or may not be present, but spinal cord involvement will always be present in NMOST plus MOGAD. How do you differentiate between the two? One, on the basis of the name of the antibody, anti-aquaporin 4 antibody versus myelin oligodendrocyte glycoprotein antibody. Another finding, suppose the antibody name is not given. Suppose antibody name is not given and you are stuck up in this situation where bilateral optic neuritis with longitudinally extensive transverse myelitis is given, then how do you answer between MOGAD versus NMOSD is what I'm trying to teach you next. That would be with the help of a fundus finding. If specifically the MCQ also mentions a fundus finding of papillitis, then you need to think in terms of MOGAD as well. So 3 disorders are just giving you a head up for demyelination that is to be taken care of. And in majority of MCQ, especially when he talks about a female with bilateral optic neuritis longitudinally extensive, considering that we are Asian country, Asian exam, so most of the time the diagnosis will turn out to be neuromyelitis optica spectrum disorder. Why I'm teaching you this right away is because see, the clinical manifestations of multiple sclerosis are very extensive. If I talk for 30 minutes about clinical manifestations and still you are not able to pick up the MCQ of MS versus NMOSD, no point of listening to this video, right? So I'm trying to give you a heads up for what they expect in an exam. So this slide would be an important one, that there are 3 demyelinating disorders that I've tried to explain at the moment, which will be affecting the brain per se. In Guillain-Barré syndrome, obviously demyelination in the spinal cord and the peripheral nerves, the lower motor neuron manifestation, flaccid paraplegia, ascending symmetrical flaccid paralysis, albuminocytological disease. So many hints in the MCQ would be there for Guillain-Barré syndrome. There nobody will make a mistake. But it is the comparison between the 3 that I've highlighted at the moment that need to be given the due respect that it deserves. Coming to the clinical features of the disease, do not answer optic neuritis or optic nerve involvement as the commonest manifestation of a disease. Yes, it is involved. That's a characteristic manifestation. But percentage-wise, if he says what is the most common symptom in multiple sclerosis, you will just have to say sensory symptoms. And the kind of sensory symptoms that are present would be like tingling sensation in the extremities, in the fingertips or in the toes. Or instead of tingling sensation, some patients might be describing that classical pins and needle sensation. So you might be under an impression that this person is having a vitamin B12 deficiency maybe, and you gave B12 supplements. In the follow-up visit, the complaint to the patient will change a bit in a sense that now the same patient who was telling you that there is a tingling sensation in the fingertips is now saying that the area appears dead or it appears raw. So hypesthesia implies that there would be a decreased sensation in the same area where initially the pain sensation was being described. And most of the time at this point, that is in point number 1, the diagnosis of this condition is not made. We usually realize that there's something seriously wrong with this patient when the patient develops the second manifestation, which is going to be a decrease in visual acuity. And there's a possibility that she may not come to you directly, but she might go to her optometrist or an ophthalmologist who might think that she might be needing a new pair of glasses. I mean, refraction errors being common in our country. So her optometrist or her ophthalmologist has suggested a new pair of glasses. But in spite of using those new pair of glasses, she's saying that her visual acuity is not improving and her vision is gradually deteriorating, and that is when she's come to a physician or she's gone to a neurologist. In fact, this lady today in her consultation is telling that she's wearing a colorful dress and she's fond of wearing colorful dresses, but she's telling you categorically that doctor, I'm not able to perceive the color of my dress. So the manifestations in this condition would not be suddenly of development for blindness like I described to you, bilateral optic neuritis, sudden onset blindness. You should think in terms of neuromyelitis optica. This is going to be a gradual onset unilateral manifestations in the form of decrease in color perception, decrease in visual acuity, or desaturation in the central vision of a patient, due to which occupational handicap can also be present. Another symptom that might be described in this patient would be that on eye movement, there might be perception of pain as well. So we will be doing a fundus examination in these patients. A large percentage of these cases might be having a normal fundus, but subsequently we will be able to have a presentation or demonstration of papillitis, and even in still later cases there would be a development of optic atrophy. That optic atrophy will explain why we can get a pupil which will be having an absent direct light reflex, because there are plaques present in the optic nerve. So subsequently, we will always read about afferent pupillary defect in this patient. What I mean by afferent pupillary defect is that if you shine a torch in the eye of this patient, the direct light reflex will be absent, but the consensual light reflex in the patient would be present. I repeat that fact once again. You read that in ophthal as well. Marcus gun pupil. In Marcus gun pupil, you're always going to read that the direct light reflex of the patient is absent. The reason why that is absent is there are plaques in the optic nerve, so current will not be able to flow forwards. But at the same time, because the contralateral circuit, we have a direct light reflex and a consensual light reflex. So consensual light reflex would be present, but the direct light reflex would be absent. So that's an afferent pupillary defect that will gradually develop in these patients. The word of caution is, from the symptoms perspective, do not straight away answer optic neuritis. The commonest presentation of these patients is sensory symptoms, and then would be development of optic neuritis. Let's look at the subsequent reasons why the patient is coming to me. This lady, like, she is staying in a hostel or she has to cook for herself, and she says fatigue is omnipresent. I always feel so tired, and there would be a weakness of the limb described. When I say weakness of the limb described, not only there is going to be a decrease in the strength, but there is going to be a decrease in the dexterity as well. What I mean by dexterity is, like, suppose you have to chop onions into fine pieces. That will require some flexibility and dexterity. One is brute strength. You need to do brute strength to do like pull-ups or sit-ups, or you need brute strength to do some bicep curls using dumbbells. But then dexterity means flexibility. Like, if you have to cut an onion and chop it into pieces, that is not too much of hard work, right? A small onion to be chopped, not like 10 onions or a dozen onions to be chopped. It's like one onion to be chopped, one tomato to be chopped for routine cooking. And she says that I'm not able to do this task. So fatigue will be omnipresent in these patients. The weakness will be affecting. Weakness would imply not only a decrease in strength, but the dexterity would be also present. And especially when the person will do any kind of exercise. Then after exercise, he or she will say that my symptoms will worsen. Though when you read about exercise induced weakness, you could also be thinking in terms of channelopathies. That's a separate video towards the end of neurology, which I would like you to listen to, for hypokalemic versus hyperkalemic periodic paralysis and paramyotonia congenita. But here the rationale is increase of body temperature will worsen the conduction block. We have a variable conduction block due to axonal damage in this condition. Apart from this, on physical examination, the doctor will be able to demonstrate, because corticospinal pathway is getting involved. So there's a spastic weakness that can explain the muscle cramps in these patients. Most of the time, patient might say, I'm very physically active. I go to gym regularly. Now I'm not able to go to the gym because I get these cramps, which is due to the spasticity. And when the doctor is examining her, you might be having presence of Babinski sign. The same Babinski sign in the MCQ can be written as long triad sign, or it can be written as extensor plantar as well. Another feature that can come up is facial nerve weakness. So another cranial nerve can get involved. We traditionally read about facial nerve weakness, bilateral facial nerve weakness in Guillain-Barré syndrome, but in multiple sclerosis also, he will talk about facial nerve weakness as well. It may resemble Bell's palsy. It will usually not be bilateral. It will be unilateral, unlike in Guillain-Barré syndrome, where I have described facial diplegia. You read about facial diplegia and sarcoidosis, and in Guillain-Barré syndrome, here it will be lower motor neuron manifestation. It will resemble Bell's palsy, but the taste sensation is usually not lost. I mean, traditionally we read about ageusia, but the taste sensation is usually not lost in these patients, which implies that chorda tympani, the anterior two-thirds of the tongue, might be saved in these patients as well. The reason why facial nerve is getting involved in this condition is due to the plaques. So that's why the manifestations are coming. Then apart from this, I mean, plaques are developing everywhere in the brain. No? So like if I go back, you see white matter areas are the ones which are getting involved in these patients. So optic nerve is getting involved, corticospinal tract is getting involved. Then there were sensory symptoms because plaques are developing with respect to the sensory areas and somatosensory areas in the brain. Cranial nerves can get involved in these patients, though even bulbar palsy and pseudobulbar palsy can be demonstrated in these patients as well due to development of plaques, but that is relatively less common, and that would mean progression of disease. If a lady with multiple sclerosis is not able to walk, lots of times she could be having cerebellar involvement. She might be having gait ataxia, because of which walking would be a problem. And if the base of the brain gets involved in these patients, if pseudobulbar palsy starts developing in these patients, then chewing activity would not be possible, swallowing will not be possible, talking will not be possible, drinking will not be possible. So we will see a progressive deterioration as plaques would be involving non-contiguous areas of the brain. Unlike in stroke, where we have contiguous areas of the brain getting involved based on vascular territory, multiple sclerosis would always have non-contiguous areas of the brain getting involved. And apart from this, obviously the visual blurring part would anyway be omnipresent. And there are two reasons actually for visual blurring. One reason for visual blurring is obviously the optic neuritis component, but the second one would be development of diplopia in these patients, and that diplopia could be occurring primarily because of multiple cranial nerve palsies as well. Now, how do you differentiate between the two? Visual blurring caused by optic neuritis and the one which is caused by multiple cranial nerve palsies. I mean, 3, 4, 6 can get involved in this condition. The plaques could be involving the cranial nerves as well. So if the diplopia of the patient resolves by covering the eye, If the diplopia tends to resolve by covering the eye, like on whichever side the third, fourth, sixth, or any of the nuclei or the nerve is getting involved, that would be contributing to muscle weakness, and the diplopia would ensue. So if you cause extinguishing of that visual input by covering that eye, then the other eye is normal and therefore the diplopia in the patient will disappear. So resolve by covering the eye. If the diplopia disappears on covering one eye, it means that the cranial nerves of one particular side, which are innervating specific muscles of the eye, are getting involved. But in case it persists in spite of covering one eye, the visual blurring is present, it implies that there is a optic neuritis component also present in this patient. In fact, there are two manifestations of the disease that I would like to highlight. One is the involvement of the medial longitudinal fasciculus that causes a manifestation called internuclear ophthalmoplegia, or we can increase the number of lesions, that is number of plaques, involving not only the medial longitudinal fasciculus on one side, but even the parapontine reticular formation, and the manifestation is called as 1.5 syndrome. So let's dive a little more deeper into the technical data. You see, the point is, if I'm asking my patient to suppose look towards the left side, then the lateral rectus muscle, which is powered by the sixth nerve, and the middle rectus muscle, which is powered by the third nerve of the opposite side, both will be working in tandem, in sync with each other, so that our eyes can fixate on any object on our left side, vice versa for the right hand side as well. So there must be some crosstalk, some cross communication that must be transmitted across, because the sixth nerve of the left side and the third nerve of the right side are working in tandem, and that crosstalk is via a white matter area called as medial longitudinal fasciculus. The same medial longitudinal fasciculus is shown in this line diagram as well, and this blue dot which you can see at the moment is representative of a plaque which has occurred on one side of the medial longitudinal fasciculus. Because of this plaque, the information flow would be hampered, as a result of which the medial rectus muscle on this side will not be able to do its job. So when I'll ask my patient to look towards one particular side, that is especially when he has to use the medial rectus muscle, which is responsible for adduction, then the medial rectus will not be able to do its job. The main message is, on whichever side the plaque is present, on that particular side, there is gonna be a ipsilateral impaired adduction. You see, in central nervous system, all the game is whether manifestation will be occurring ipsilaterally or whether it will be occurring contralaterally. So what you can see here is, on whichever side of the plaque is present in the medial longitudinal fasciculus, therefore on that particular side, there is gonna be a ipsilateral impaired adduction. As far as the opposite eye is concerned, everything looks fine, because on the opposite side there is no lesion. So let's now look at a simple activity that we'll be doing in this patient. I'll be asking this patient, one, to look straight ahead like I'm looking into the camera. Then I'll be requesting this patient to look towards the left side, and then I'll be requesting this patient to look towards the right side. Let us look at what happens. I'll just zoom in into image number 1 and 2 initially. Image number 1, you can see patients looking straight ahead. So far so good, no problem. When I requested this patient to look towards the left side, you can notice that both the eyes can move appropriately. So that means there is no problem on the left hand side per se. At the moment, I don't know where the plaque is, but at least what I can say with this horizontal gaze with a sync movement occurring with respect to the lateral rectus of the left hand side and medial rectus of the right hand side, there is unlikely to be involvement of the medial longitudinal fasciculus on the left. But the situation will change when I bring in the image number 3. I have requested my same patient to now look towards the right hand side and see what happens. You will notice that on one particular side, there is a clear-cut impaired adduction. This particular eye should have been showing adduction, but that adduction is not happening. In fact, the eye is still looking straight ahead. That means medial rectus on this particular side is not functioning, and the reason for that could be a plaque present on the same side of the medial longitudinal fasciculus. Now look at what happens in the other eye. The other eye will obviously move normally, because see, lateral rectus of the opposite side is absolutely not having any problem. The LR on this particular side will be able to work like normal, and therefore the eye will be able to abduct, but the brain will perceive this as an overcorrection. I repeat my statement. I'm saying that on whichever side the plaque is present, impaired adduction, understandable. On the opposite side, the lateral rectus, which is powered with the sixth nerve, will do its normal job, but this normal job will be perceived by the brain as overcorrection, And to counterbalance this overcorrection, there will be a development of nystagmus in this patient. The main concept, why do you get a nystagmus in the contralateral side, is because the brain will perceive the normal movement on the right eye of this patient as an overcorrection, and to counterbalance this overcorrection, there will be a nystagmus present. So the final output is like this. What you need to remember for your exam is that every time there is involvement of medial longitudinal fasciculus in multiple sclerosis, on whichever side the lesion is present, obviously a ipsilateral impaired adduction will be occurring, but there would be a contralateral nystagmus, and this nystagmus would be described for the abducting eye. And the rationale behind this nystagmus in the abducting eye was that the brain was able to perceive this activity as overcorrection, so it's trying to counterbalance it, it's trying to neutralize this activity. Once we get these 2 points right for the plaque in the medial longitudinal fasciculus, which is finally called as internuclear ophthalmoplegia. Why do we call it internuclear? Because communication between the sixth and the third, the two nuclei, is getting hampered through a white matter tract, which is responsible for crosstalk, is hampered in this case. And now what I will do is I'll show you one more diagram in which the number of lesions has been shown to be increased. Like in this particular diagram, you can see I have shown lesion first on the same side of the medial longitudinal fasciculus. This lesion is identical to one that was shown in the previous image also, but then I have also shown involvement of the sixth nerve nucleus / involvement of the parapontine reticular formation, and you know that this nucleus will be in crosstalk with the third nerve nucleus of the opposite side as well. So now let's look at the manifestations that will be happening in this patient. Just follow my marker at the movement. The first thing that I want to say is, because the sixth nerve on this particular side, there is a plaque present. So the lateral rectus muscle on this particular side will not be able to function. There's a minus sign put here because the sixth nerve nucleus is hampered. Sixth nerve powers the lateral rectus muscle, and therefore the abduction in this eye due to loss of information flow in the lateral rectus would not happen. The second problem in this patient would be due to this particular side lesion, that is medial longitudinal fasciculus. It is sending information to the third nerve nucleus. Therefore, even the medial rectus muscle for this particular eye will not be able to move, and I put another minus sign here. So what I can say overall is, because there are two lesions present here, both the abduction and the adduction of this particular eye would not be possible. So one eye is neither gonna abduct and neither is gonna adduct. Reason I'll say once again why it will not abduct, because the sixth nerve nucleus is getting involved, and why the eye will not show adduction is because the medial longitudinal fasciculus on this particular side is also getting hampered. Now comes the critical part, which is that this sixth nerve nucleus is obviously going to be in communication and crosstalk with the third nerve nucleus of the opposite side. That means that even the medial rectus of the contralateral eye will not be able to function, and therefore in green I'm representing the only movement possible in this chap will be the abduction of the contralateral eye. If you look at the data on the slide at the moment, what do you mean by 1.5 syndrome? One eye is not moving at all, neither adduction, neither abduction. And the half movement that is possible is only one movement possible. What is the movement possible? Abduction in the contralateral eye. Well, the reasons behind this I have enumerated. I'll just do it quickly once again. Why one eye is not moving is because the sixth nerve nucleus is also hampered, so abduction is one. And because the same side medial longitudinal fasciculus is also hampered, so therefore the adduction part is also hampered. So one eye is not gonna either abduct or adduct. In the contralateral eye, the only movement that is possible is gonna be the abduction component, because the sixth nerve nucleus here is doing fine, the parapontine reticular formation is doing fine. So this manifestation is what is technically called as 1.5 syndrome, and on the basis of this information we can quickly just summarize the eye involvement in multiple sclerosis. Obviously we have optic neuritis, they can be visual blurring, so that is standard and understandable. But yep, we can be having a horizontal gaze palsy. A horizontal gaze palsy can be explained by isolated lesion in the sixth nerve nucleus. On the other hand, if the lesion occurs in medial longitudinal fasciculus, then the manifestation is called as internuclear ophthalmoplegia. The profile of this patient would be impaired adduction on the same side wherever the lesion is present, and the contralateral eye will show a nystagmus, rationale for which I've explained twice already. And then if you increase the number of plaques, then the manifestation is called as 1.5 syndrome. In this, the number of lesions would be 2 on the same side itself, medial longitudinal fasciculus. I mean, there can be various permutation combinations. Talking about what we usually get, that is the sixth nerve nucleus would be involved, which will also be written as PPRF. I mean, this is in communication with PPRF. So parapontine reticular formation, that would be 1.5 syndrome. Then we'll do a funny mathematics part here, that the seventh nerve can also be involved, seventh nerve nucleus can be involved, and I mean 1.5 manifestation is anyway there. So sometimes we might even say 8.5 syndrome. Now Now that is a little unlikely to be present, but still 8.5 syndrome is described in books, so that's why I thought I should mention about it. And the fifth manifestation in these patients is very characteristic and is referred to as the pendular nystagmus. So just like you guys are comfortable with downbeating nystagmus for cerebellar lesions, as far as pendular nystagmus is concerned, one of the important reasons why we get pendular nystagmus would be primarily to be remembered as multiple sclerosis. So these are the eye involvements in multiple sclerosis over and above the aspect of optic neuritis and development of blindness and plaques on the optic nerve and an afferent pupillary defect, because there would be plaques in the optic nerve. When you shine a torch on that particular side in the eye, direct light reflex will be absent. But the information can relay by the light reflex from the opposite side. So consensual light reflex would be present. So in ophthalmology, they're going to call it Marcus gun pupil, though we simply tend to call it a relative afferent pupillary defect. I mean, the description which I mentioned earlier, I can just add a word to it, that is afferent pupillary defect is also referred as Marcus gun pupil in opthal. And in medicine, we simply call it a afferent pupillary defect or a relative afferent pupillary defect, in a sense that one eye, the optic nerve, is involved and the other eye can be normal as well. Bilateral optic neuritis, as I've highlighted earlier, can be manifestations either with neuromyelitis optica spectrum disorder, or it can be seen with MOGAD. So these are like, especially the eye manifestations are the reason why multiple sclerosis as a topic is being discussed before you at the moment. And now let's focus on a couple of other manifestations that can be developing in these patients as well. So the sixth manifestation can be involvement of plaques in the cerebellum. You see, this disease has a tendency to involve the white matter area. So optic nerve, corticospinal tract pathways getting involved. Medial longitudinal fasciculus is a white matter tract. Parapontine reticular formation is a white matter tract. So non-contiguous white matter areas are the ones which would be involved in this patient. Now, cerebellum is responsible for maintenance of balance. So a bit of physiology here. These are primitive terms, but these would still help. Like, to maintain the balance of the trunk, we have archicerebellum, and therefore if you are having plaques in the archicerebellum, the same chap would end up with development of truncal ataxia. On the other hand, the most advanced part of the cerebellum is what is called as neocerebellum, and if this gets hampered, then the manifestations occurring in the patient would be in the form of limb ataxia. Therefore, you will be able to demonstrate this limb ataxia by doing a finger nose test in the patient, and in finger nose test there would be always overshooting of the target, that is called as pass pointing. There would be dyscytokinesia in a patient. So in the same question of multiple sclerosis, which will initially begin with sensory complaints, then will progress on to involving the optic neuritis component, the eye manifestations that I described. We'll also talk about cerebellar involvement. Then comes ancillary symptoms, which are high frequency, brief duration symptoms, and the usual triggers for this could be in the form of sudden movement or a hyperventilation. Traditionally, we read about hyperventilation triggering absence seizure, but today I'm teaching you that some symptoms of multiple sclerosis can be triggered by hyperventilation or sudden movement. One is Lehermite symptoms. In Lehermite symptoms, it basically means that when you do a sudden neck flexion in this patient, the sudden neck flexion will be responsible for development of shooting pain. This shooting pain will be starting from the neck area of this patient and would be going down towards the lower part of the spine. So basically the severe amount of pain. I mean, traditionally we read about Lehermite sign where sudden neck flexion results in a shooting pain in the back of the patient, traditionally with tapes dorsalis. But with neurosyphilis becoming relatively more common, the main feature is Lehermite symptoms, where the neck flexion causes a shooting pain or a terrible pain that would be radiating downwards from the neck downwards towards the spine, the lower part of the spine of this patient. Then this patient can say manifestations of traditional trigeminal neuralgia, which is that when he's shaving in the morning and the shaving razor goes over a particular part of the face, or like if it's a young female, she may not be shaving, but she's saying that I'm washing my face, and if I splash water on my face, or like she's put on some makeup and she says when I'm removing this makeup and like over one particular part of my face, when I put pressure, there is like an excruciating pain. I feel as if somebody is cutting the side of my face with a piece of glass. So there would be lancinating pain described by the patient that is called as trigeminal neuralgia due to plaques in the trigeminal nerve. And then if the plaques are in the glossopharyngeal nerve, patient might even complain of painful swallowing. So Lehermite symptom and trigeminal and glossopharyngeal neuralgia are like short duration, high frequency symptoms, but yeah, extremely painful. Then there could be involuntary twitching around the eyes, that is facial myokemia. Myokemia basically means twitching of muscles. And then bladder involvement can also be seen in these patients. Well, the reason for this bladder involvement can be spinal cord involvement. If it's a upper motor neuron involvement in this particular case, then the bladder involvement can result in development of urgency. What I imply is that if you have a upper motor neuron lesion with respect to the bladder, the lesion is above the level of S2, S3, S4, then the plaque would be contributing to, will act like a upper motor neuron lesion, and therefore be a spastic bladder, and spastic bladder will contract again and again, so there can be a urgency occurring in this patient. So I can say that the detrusor muscle of this patient will be showing a hyperreflexia, and therefore this detrusor hyperreflexia would be manifesting in the form of urgency in these patients. Another manifestation which can be seen in these patients is detrusor dyssynergia. Because of this detrusor dyssynergia, the person would either be having difficulty in initiating the act of urination or stopping the act of urination. See, a normal person can increase the speed of urination, decrease the speed of urination, stop the act of urination midway. But in this patient, because I'm saying the word dyssynergia, again because of lesions innervating the bladder circuit, therefore detrusor dyssynergia means one, the person will be having difficulty in inability to initiate the act of urination. Just like in bladder outlet obstruction or benign prostatic hyperplasia, because there's a genuine physical obstruction, here there's a neurological illness which is causing inability to initiate urination. Or at the same time, I can say there could also be a difficulty to stop urination midway as well, or difficulty to increase the speed of urination, or difficulty in stopping the act of urination midway. I mean, voluntary control is the one which I'm talking about would be affected in this patient. Then sexual complaints would be their ability to, in a male patient, ability to sustain erection, or in a female lubrication of genitals would be hampered. Cognitive defects, yes, that's an important part, because traditionally in this disorder, we always read about non-contiguous. The diagnostic feature is obviously non-contiguous white matter involvement, but even cognitive defects, epilepsy and falls can be seen in these patients. Utthav symptoms I've already explained, that every time there is going to be increase in the body temperature of this patient, heat exposure, that could be in the form of a workout in a gym, taking a hot shower, steam bath, sauna bath. Every time there is going to be an increase in body temperature, there is going to be development of neurological symptoms in a patient, or whatever pre-existing neurological symptoms are present, those neurological symptoms can actually deteriorate, which is called as Utthav phenomenon. And then fatigue is a universal problem with all patients of multiple sclerosis, which would result in work related disability, especially in Western countries where people get paid by the hour. Like, lots of time people may not be having high paying jobs and permanent job, and they may not be having proper backups also. So especially like person is working in Starbucks or working in some company where they get paid like $10 or whatever XYZ amount per hour, then a person in Western country earns money. Not like in India where there's a fixed amount of money that is being paid, it is per hour payment. So the amount of economic work a person would be able to do would be hampered. So because of the continuous fatigue present and symptoms that are worsened on heat exposure, so work related disability would anyway be present. So these are a couple of ancillary symptoms which are or can be given in MCQ multiple sclerosis. And before we talk about the revised McDonald's criteria and the workup of this patient, the main reason why you are supposed to remember this topic from clinical domain perspective is the eye profile which I manifested or explained before you, especially part number 2 and 3, internuclear ophthalmoplegia. Basically, if you go by English only, internuclear ophthalmoplegia, the medial longitudinal fasciculus, which is responsible for cross-talking between the LR of one side and the MR of the contractor side, that cross-talk is hampered. And then 1.5 syndrome, you have two plugs present, parapontine reticular formation / sixth nerve and the medial longitudinal fasciculus, due to which one eye is not going to move at all, no adduction, no abduction, and the contralateral eye only one thing is going to be seen. Contralateral abduction is the only thing that's going to be present. Now that I am not a very big fan of mnemonics and I believe in hardcore data, but since if you're reading or listening to this data the first time, then this mnemonic with respect to sclerosis should help. So one of the earliest manifestations that develops in this disease would be sensory symptoms, which can be misdiagnosed as commonly vitamin B12 deficiency, and then the symptoms will progress to the level that the person will say, I cannot feel my hand, or there's a numbness, or I feel as if the part is dead. Then C would stand for cerebellar involvement in these patients, which can cause difficulty in walking, difficulty in balance, and therefore a lot of these patients of multiple sclerosis might be bedridden and may not be able to even feed themselves. They may not be able to eat and drink, because once the cerebellum gets involved, that means even the brainstem could be having plaques, and therefore multiple cranial nerve palsy, especially 9th, 10th, 12th can occur. And due to the involvement of the bulbar or the pseudobulbar palsy, these patients may not be able to talk. The words I'll be saying in disability score would be can't talk, can't eat, can't speak, can't drink. That's because of the bulbar palsy, because cerebellum got involved, the balance issues are there, and then subsequently even eating, drinking, and things which we don't even think about, like talking, eating, drinking, swallowing, those parts could be hampered. Alphabet L stands for very classical manifestation that we traditionally used to read with the Lehermite syndrome, that shooting pain in the neck, and now we read about this as an ancillary symptom in multiple sclerosis. I is the eye manifestations, about which I have already talked about in detail. Then alphabet R is mainly to remind you that even parapontine reticular formation, the R of the parapontine reticular formation is the one which is to be remembered. And if this gets involved, then either you'll have, if only PPRF involvement, then you have is lateral gaze palsy. But if it is PPRF plus medial longitudinal fasciculus, then it would be 1.5 syndrome in a patient. So O here is not for the 1.5 syndrome, it is the optic neuritis component. I'll say that again. If we are having lesion in PPRF plus medial longitudinal fasciculus, both on the same side, that is when we get the traditional 1.5 syndrome in a patient. And the last alphabet S can be used to remember the spastic weakness that will be occurring. Apart from this spastic weakness, which will cause a work-related disability, the patient might be perceiving that as muscle cramps, like initially was a physically active patient, and now he's saying that he or she is not able to work out in a gym because they tend to develop cramps very easily. And that's when you examine this patient, you are able to perceive the spasticity, and you will also able to pick up Babinski sign or extensor plantars. So in the same question, cerebellar manifestations will also be there, and even upper motor neuron manifestations in the form of Babinski would also be present. These are just effort to make you remember some of the important features overall as a disease, because this would have a wide range of presentation spanning over 2 pages of Harrison. You can understand Harrison font size is very small. So over 2 pages of Harrison means substantial amount of data which I've tried to compress into the important aspects which you're supposed to remember. Next is the turn of revised McDonald's criteria. So we need to remember minimum of at least 2 attacks should be present, that is 2 episodes of symptoms. The duration of each symptom should be lasting for more than 24 hours. That is obviously to rule out possibility of transient ischemic attack, and along with 2 attacks or 2 symptoms, how many minimum signs should be present? Should be 2 at least clinical signs, and we should be able to demonstrate these in 2 non-contiguous areas of the brain. You see, contiguous areas are following the vascular territory of the brain. That would mean stroke manifestations. But at the moment, we're talking about non-contiguous areas of the brain, predominantly white matter tracts, which are getting involved in this condition. The white matter tracts that must be remembered getting involved in this condition are medial longitudinal fasciculus, optic nerve, and then cerebellum. These are like the common involvements that would be described in a question. So we are having 2 symptoms and we are having at least 2 clinical signs. That is when we are thinking in terms of multiple sclerosis. But what happens if only 1 clinical sign is elicited? Like by what only 1 clinical sign, I mean that person might be having extensor plantars or Babinski sign that is elicitable. Then for the second clinical sign, like I said, 2 clinical signs appreciated in 2 non-contiguous areas, cool. But if it is only 1 clinical sign, for the second one, we need to document the second involvement in the brain of this patient by special studies. And that special study can either be by doing a contrast-based MRI or a gadolinium-based MRI, which will show damage to the blood-brain barrier. Or sometimes the plaques can be so small that they may not be visible on a contrast-based or even a plain MRI. And then I will be using visual evoked potential for these patients. So I repeat the fact once again, either it is 2 symptoms with 2 signs or it is 2 symptoms with at least 1 sign. But then the second involvement, which will be present in this patient, will be demonstrated. I mean, that's the important thing, that even if the clinical manifestation has not become very full blown, there must be demyelination occurring in the brain. I mean, the manifestation is waiting to happen. It has not occurred in my patient. I can still prove that the involvement in the patient has started, and the second involvement is demonstrable by either MRI or a visual evoked potential in multiple sclerosis typical areas. Now, what I mean by multiple sclerosis typical areas would be white matter tracts only. But in a multiple choice question, to make it sound sophisticated, look at how he will write white matter tract involvement. He will write like juxtacortical area. Now, what you mean by juxtacortical is that junction of the white matter and the gray matter. The second term that could be written as a typical white matter involvement in the brain is periventricular area. This I had mentioned even in the starting of the video lecture, that there is a perivenous demyelination which will be occurring perpendicular to the ventricular surface. And to just highlight this, I would like you to focus on this image. You can see that this would be corpus callosum, below this would be the lateral ventricle that is present, and then you can see these finger-like projections which are just standing up perpendicularly to the ventricular surface. So once again, I've highlighted what I said in the opening few minutes of this video, that is the presence of Dawson fingers, and these Dawson fingers are occurring in periventricular area. So let's look at the MS typical areas or multiple sclerosis typical areas. How would we describe them in the MCQ? He'll either use the word juxtacortical, or he will use periventricular, or the involvement of the cerebellum. How will he write cerebellum? Cerebellum is a little inferiorly located, so he will write the word infratentorial area involvement, or like spinal cord can also be involved. Obviously, spinal cord involvement is of paramount importance with respect to transverse myelitis component in neuromyelitis optica spectrum disease or MOGAD that I spoken about earlier. But yeah, spinal cord involvement can occur in multiple sclerosis also. So urinary incontinence can occur. I mean, the same lady who was having visual blurring, she says like, I was sleeping at night and in inbarlante urine got passed. And she says, doctor, it's embarrassing to say for adult person urine got passed. I thought it is accidental once, but it happened again and again. And then, symptoms tend to improve also. I mean, in these patients, you could be having improvement between two discrete attacks. So that's where relapsing variety of multiple sclerosis is the term that is used. Out of these four white matter areas that are described, the names are juxtacortical, junction of gray matter, white matter, periventricular, the Dawson finger area that I showed you, then is infratentorial cerebellum and spinal cord involvement. Then at least two out of these four areas should be involved and should be demonstrated in T2 weighted images on a MRI. That would be the second important. I mean, two out of these four areas getting involved would be a second involvement demonstration by special studies for these patients. So let's just revise this particular slide. The revised McDonald's criteria go like this. He says at least two symptoms with two signs or two symptoms with one sign, but the second involvement, which is present but has not caused a full-blown clinical sign, can be demonstrated by the lesions in any of the following areas. This is description for the relapsing variety of multiple sclerosis, but sometimes you could be having primary progressive multiple sclerosis also. In primary progressive, like urinary incontinence occurred, and then the symptoms did not improve. It is continuing, and then visual blurring is occurring, and then patient is having truncal ataxia, and then there is development of limb ataxia, another involvement in the form of spastic weakness. So one after the other neurological symptoms are occurring, relentless course, fast progression of manifestations are occurring. That is primary progressive multiple sclerosis. Unlike in initial part, for relapsing variety, I was saying like this lady, she says, I had urinary incontinence for a couple of days, went away. Then I had muscle spasms and I stopped going to the gym. Now I am relatively better. And then she had this visual blurring that persisted for short duration, is gradually improving. There are like manifestations which would occur like this in the form of symptoms coming, then decreasing in severity. Then a new one is coming, the previous one is decreasing in severity. So this that I've described, where you are noticing some asymptomatic periods also present, like in January a symptom occurred, then February, March was okay, then March, April symptoms are occurring, then again August there's a new symptom coming up, and then September, October, November have been terrible time for these patients because the symptoms have not completely disappeared. That is the usual description for relapsing variety of multiple sclerosis. We can have a combination also, which I can now say that if I'm talking about 2024 in a patient, symptoms used to come, symptoms used to go away, asymptomatic period. And now the patient is saying that my symptoms one after the other are coming. So I'm going to call it secondary progressive multiple sclerosis. MCQ wise, primary progressive has a very aggressive course. We treat it with ocrelizumab. That's the drug of choice for this condition. And he says that if there is progression of symptoms continuously for more than 6 months without any asymptomatic periods in between, then we also need to do documentation of intrathecal immunoglobulin G synthesis. How do we do that? We will be doing a test by the name of CSF electrophoresis. So what is the role of CSF electrophoresis? Well, it primarily has a role for diagnosis of primary primary progressive. I said it primarily has a role in diagnosis. Obviously, in primary progressive, imaging evidence will also be there. But in primary progressive, we also can be using CSF electrophoresis for diagnosis. And what are the findings on CSF electrophoresis? One, will be able to show oligoclonal bands. Oligoclonal bands means that oligo means that they are against a single target. I mean, the plasma cells and the B cells here are producing antibodies against the myelin basic protein, causing demyelination, and therefore the axon gets exposed, and then there's axonal damage, and therefore the axonal damage manifests in the form of a conduction block. And then we also calculate what is called as a CSF immunoglobulin G index. In this, what we do is, in the CSF of the patient, we'll take into consideration the values of IgG divided by albumin, and then in the blood also we'll take care of IgG versus albumin. We basically want to prove that numerator amount will be more than the denominator. That is because in this condition, we can be having antibodies which are coming from the blood into the CNS, but primarily in this disorder, there is going to be intrathecal local synthesis of antibodies. So the numerator value, I mean, this value will always be more than 1, I can say, as a ratio, because the numerator will be having a higher concentration of immunoglobulin G because of local synthesis of immunoglobulin G in the CSF of this patient. This CSF electrophoresis is used for diagnosis, especially in primary progressive variety of multiple sclerosis. For the routine variety, MRI and then presence of 2 signs and 2 symptoms is more than sufficient. Let's have a quick look at the workup of these patients. One test that we can do is gadolinium enhanced MRI. This would be answered by you in the exam as the imaging modality of choice. And well, what would be the findings that can be demonstrated? Because there's a damage to blood-brain barrier, there would be gadolinium enhancement. They can be plaques that could be developing in the brain. If the plaques are very small, we can do a visual evoked potential as well. And then there are 2 very classical terms that I've said earlier, Dawson fingers and black hole. Dawson fingers as a finding would be T2 weighted images. Black hole would be visible on T1 weighted images. And if the plaques are very small, like if you look at the optic nerve representation here, ultra small, 0.1 millimeter, I'm not even 1 millimeter, I'm saying, then MRI will not be able to prove, or MRI will be blind to it. So we can do a test by the name of VEP, a visual evoked potential, that will show a prolonged latency because the damage in the optic nerve is present. Plus we can calculate CSF immunoglobulin G index. We can do a CSF electrophoresis in which at least 2 or more, that's the statement to be remembered, at least 2 or more oligoclonal bands would always be present in multiple sclerosis, especially the primary progressive variety of multiple sclerosis. It's important to demonstrate the presence of these oligoclonal bands. Even in neuromyelitis optica, I'm going to talk about these oligoclonal bands, but they're not going to be present in all cases. But in multiple sclerosis, this is definitely going to be finding and is an important diagnostic criteria for especially the primary progressive. When you do lumbar puncture, you can check out the cell counts as well. So the cell counts in these patients in multiple sclerosis, because it's an autoimmune condition, so the cell counts can be a little more than normal. Normal is 0 to 4, 0 to 5 lymphocytes per cubic millimeter. So in this case, more than 5 cells per microliter can be present. But remember that he says this in a textbook, so I just want to highlight that if the number of cells in the CSF are more than 75 and the proteins are more than 1 gram and there is non-contiguous involvement in the brain per se, which is visible even on an MRI, then alternative diagnosis should be considered. Like even neurosarcoidosis can be having multiple involvement in the brain. So white matter involvement can occur due to various diseases, and one of the hints that tells you that alternative diagnosis is to be considered, one would be cells more than 75 and CSF protein value more than 1 gram. In multiple sclerosis, the cell count will be slightly increased, but gross elevation of proteins more than 1 gram is unlikely to be present. And then obviously in multiple sclerosis, if the plaques are very small, then you might have a difficulty in diagnosis because MRI is going to give a clean chit to the patient, but visual evoked potential will be able to do its job. Point number 4, 5, 6 are for alternative diagnosis. We'll do an autoimmune panel because autoimmune diseases, Behçet's disease, neuro-Behçet's can again cause neurological manifestations. Serum vitamin B12 levels have to be done because even vitamin B12 deficiency can be having involvement of the spinal cord as well as of the peripheral nerves. So combination lower motor, upper motor manifestations can be present, and treponema antibody levels to rule out possibility of neurosyphilis as well. So 4, 5, 6, I don't think so would ever be asked to you in the exam because these are obviously for alternative alternative diagnosis, but the main tests which are available for diagnosis, he says there's no single test for diagnosis. We need a battery of tests. We need gadolinium based MRI, we need evoked potential in a patient, and CSF immunoglobulin G index with that peculiar finding of CSF electrophoresis. I mean, this particular term, CSF immunoglobulin G index or CSF electrophoresis, is not read by us in any other medical disorder. So these are the tests which are useful for diagnosis of this condition. Now, before I describe the treatment of this condition, I would like to focus on EDSS, that is Expanded Disability Severity Score, which we have created to gauge the amount of disability a person is having due to MS. I mean, this disease will immediately not cause a mortality, but morbidity part will anyway be there. So I'm going to give a score of 3.5 to a patient who's fully ambulatory. Like, this patient is able to go about his or his daily chores, but the problems are like in the form of urinary incontinence that has happened a couple of times, plus visual blurring is occurring in these patients in one eye, but otherwise as such the patient is able to work on computer, go to his job. But there will be a progressive downhill course in this patient, as the plaques will be involving the corticospinal tract and then involving the cerebellum and then even the brainstem of this patient. So this particular person can become a helpless bedridden patient. And at the same time, this person at the moment can at least talk. At least he can say, I am thirsty, please give me water. And when I give him water, he may not be able to drink it fast like us, because probably the brainstem is in the process of getting involved, but maybe he might be able to swallow with help of a straw and there would be no aspiration, and he is also able to eat as well at the moment and drink with help of a straw. He can't get out of the bed, but we can make him propped up in a bed. We'll have a full-time nurse dedicated for this guy. He can communicate his needs. Like, if he says he wants to urinate, the nurse can help him around with it, and they can help him eat and drink as well. But if I describe a helpless bedridden patient of multiple sclerosis due to extensive cerebellar involvement, corticospinal tract involvement, and at the same time the bulbar palsy or the pseudobulbar palsy has extended so fast that the 9th, 10th and the 12th nerves are involved, that this person can't talk, can't eat, can't drink, also can't even drink with the help of a straw, and the risk of aspiration is very much there. That would be a score of 9.5. So the point is, with that extreme amount of disability that can occur, do we have treatments available which can actually modify the progression of the disease? Our objective is to put brakes. Our objective is to prevent this deterioration of the patient from happening, where a lady who was fully ambulatory and was able to go to her gym, at least able to go to her office and was economically productive, goes into a deterioration state where person is bedridden and can't talk and can't eat also. Well, yes, we have two drugs available, and we'll talk about a couple of monoclonal antibodies which are useful for management of this patient. We also have a condition called as benign multiple sclerosis. As the name suggests, benign multiple sclerosis, well, there is no neurological deficit that would be occurring in this patient. I mean, the MRI burden might be present, there might be lesions present, but there is no neurological deficit per se present, so it would not require any treatment. But if it is an acute attack, initial demyelinating attack which is causing blindness or is causing other manifestations that I mentioned with the mnemonic sclerosis that I mentioned, then initial demyelinating agent, the management, initial demyelinating event that occurs, will be using methylprednisolone. We use methylprednisolone IV along with plasma exchanges for neuromyelitis optica as well, and similarly even for multiple sclerosis initially we'll be using intravenous methylprednisolone. However, if the patient's EDSS score is on the lower side, if the MRI burden is low, then we can be using oral S1P modulators. Oral S1P modulators would be like fingolimod or a couple of others that I'll be describing before you, or teriflunomide. So depending upon how severe the disease is and what is the burden of the disease per se, we'll be planning our treatment. What I mean by planning the treatment is that I want to prevent development of recurrent attacks of neurological symptoms in these patients. So let's first talk about highly effective drugs which are recommended in relapsing variety of multiple sclerosis. In the previous version 4.0, 5.0, you would have read mainly about me talking about beta interferon and glatiramer. We still use them at the moment, but it says that these two drugs, which were initially the first line drugs, should be used in only resource limited settings, and now we should go out all guns blazing with highly effective monoclonal antibodies for management of these patients. So I'll be teaching you 4 drugs. The first 3 will be acting on B cells and the last one will be acting on the T cells. In fact, the one which will be preventing the autoreactive T cells from causing damage to the blood-brain barrier and will also be preventing their migration into the brain is natalizumab. If you contrast this, the highly effective drug for B cells would be ocrelizumab, How this molecule will work is that it will work against CD20. It will basically selectively deplete the mature B cells, which are going to be having CD20, and they are the troublemakers, but the original humoral immunity of the patient will be not affected. Now, with monoclonal antibodies, there is always a problem. We give monthly infusions of it. There can be risks like anaphylaxis also. So, do we have a drug or an injection that can be given to the patient subcutaneously instead of an intravenous infusion, and can be self-administered by the patient as well? Yes, we now have that molecule available. The name is ofatumumab, and ofatumumab, the advantage of this molecule is that not only this is available as a subcutaneous injection, the advantage will be that the person will not have to come to the hospital for getting an infusion done. Like, the administration can be done by the patient himself. So it's a self-administration that would be done on a monthly basis. And the advantage of ofatumumab is that it will decrease the MRI burden in the patient. It will decrease the new, in fact, this is important MCQ wise, that which drug as a monoclonal antibody in relapsing variety of multiple sclerosis will decrease the new T2 lesions. Then Harrison has given a table in which he has mentioned that the new T2 lesions developing in a case can be prevented or can be reduced by as much as 95% by the usage of this self-administered subcutaneous monthly injections of ofatumumab. As far as the mechanism of action of these drugs is concerned, it is uniform anti-CD20 molecules. And the third one here is obviously the one which we study in hematology also, that is rituximab. With rituximab, there can be a risk of development of progressive multifocal leukoencephalopathy. But on a comparison basis, when he describes the data, the progressive multifocal leukoencephalopathy risk is highest with natalizumab. The risk is mentioned even with rituximab as well, but with natalizumab, which is a molecule that will act by binding to the alpha-1. I mean, we have that integrin available, or alpha-4 beta-1. So it binds to the alpha subunit of that integrin, and that prevents the binding of this autoreactive T cell to the blood-brain barrier, and therefore the damage to the blood-brain barrier can be prevented. Because this progressive multifocal encephalopathy, PML, is caused by the JC virus. You are aware, JC virus would be John Cunningham virus. JC virus causes progressive multifocal leukoencephalopathy, and because we as doctors are aware that the administration of natalizumab causes a substantial increase in the risk of progressive multifocal leukoencephalopathy, so he says that we must do testing for antibodies for the JC virus. He says that natalizumab injections should always be used in those patients who are JC antibody, John Cunningham virus antibody negative patients. Obviously, like, the basic essence of medical science is first to no harm to the patient. If I know that they can be worsening of the current neurological status of a patient by this JC virus. JC virus lives in symbiotic relationship with the human body. It is excreted in urine of normal people like you and me. So the same virus that can live in a symbiotic relationship with our body and does not cause any harm can be causing worsening of neurological status if person is on natalizumab, which will neutralize the T cells in a sense that it will not kill the T cells, but it will prevent the binding of the T cells. The T cells would be having integrins, that is cell addition molecule, by which it binds to the endothelial cells, so that binding part would be hampered. But because this risk is very much there, he says that this molecule should be used in JC virus negative patients only. So highly effective drugs are three of them: ocrelizumab, ofatumumab, and rituximab. And the top three drugs which are mentioned on the left hand side of this are anti-CD20. CD20 is expressed on mature B cells. So the first three drugs are gonna selectively deplete the mature B cells while preserving the humoral immunity of a patient. For natalizumab, the cell addition molecule concept, or like the integrin binding to the endothelial cells, that integrin binding to the endothelial cells is the one that is hampered. And once we talked about highly effective drugs, now we'll talk about moderately effective drugs. So he's talked about three categories which are frequently used in relapsing variety of multiple sclerosis: highly effective, then he's talked about moderately effective, then he's talked about modestly effective. So a bit of English here. Let's now look at the moderately effective drugs which are to be remembered, and these would be called as S1P modulators. Before I write down the name, I'm very sure you would have read them from pharmacology as well. The S1P modulators would be like fingolimod or ozanimod or ponesimod. The mechanism of action of these drugs would be that they will prevent the egress of the lymphocytes. See, the white blood cells are the villain in this case. So we're trying to neutralize the autoimmunity component in this condition by preventing the egress or coming out of the lymphocytes from the secondary lymphoid organs. So a bit of revision of pharmacology as well. The molecule S1P modulator acts by preventing the egress of lymphocytes from secondary lymphoid organs. And well, what are the drugs available in this case? We have this molecule fingolimod. The side effect of fingolimod, I think, is the one which is probably going to be asked in the exam. I'll just write down the side effect in a while, but I can just mention another one. The main reason, these molecules will be asked to use mainly for the side effect component, because anyway, they are moderately effective for management of multiple sclerosis, but he would like to ask you from the treatment perspective, the ones which are highly effective. And for the drugs that I'll mention subsequently, it is mainly the side effect component that is would be asked, like fingolimod or ozanimod. Well, one of the important side effects to be remembered is heart blocks. Apart from this, there can be a chickenpox reactivation. That's standard. Any immunomodulator drug can cause shingles and a chickenpox reactivation. But what I'm worried about from the exam perspective and MCQ perspective is the visual impact that can happen in this particular case. Already remember, our patient was having involvement of the optic nerve, and now macular edema can be present, or heart blocks can be developing due to the use with fingolimod per se. And then another molecule that can be used for management of this condition is DMF, that is dimethyl fumarate. Well, we traditionally read about this molecule. No, fumarate looks like a very heard molecule from the biochemistry perspective. So, well, I can say that the mechanism of action of this drug as well is more from the biochemistry perspective. How this drug will work is it will modulate the release, or it will inhibit the release of the pro-inflammatory cytokines, because ultimately whenever B cells and the T cells would come into picture, they would be pro-inflammatory cytokines also present. Like in neuromyelitis optica, I've spoken about interleukin 6 being elevated, glial fibrilic acid protein being elevated. So similarly, even in multiple sclerosis, autoimmunity, there would be some local cytokines that would be present. So modulation of the release or inhibition of the release of the pro-inflammatory cytokines is how this particular molecule would be working. And there are two drugs that I mentioned, sphingosine 1P modulators and dimethyl fumarate. One will act by preventing the egress of lymphocytes from secondary lymphoid organs. Second one will modulate the release of pro-inflammatory cytokines. And these molecules would be considered as moderately effective for management of relapsing variety of multiple sclerosis. The drugs that I'm talking about right now on this particular slide are the ones which were mentioned in the previous editions as drug of choice for multiple sclerosis. In the previous editions, we used to read as beta interferon. Either the varieties were 1A or 1B or pegylated. But the point was subcutaneous injections of interferon were the ones which were described as the drug of choice. And now he says that this drug approach should be used only in resource limited settings. These drugs are expensive, but he's saying that even much more expensive drugs, if a resource limitation or cost is not a consideration, go out aggressive and use drugs like ocrelizumab or natalizumab. But if it is a cost consideration to be considered, then we can be using beta interferon. Well, beta interferon will modulate the autoimmune response. And then what does glatiramer do? Glatiramer will be providing the building blocks, or it is basically a peptide copolymer. In fact, from the MCQ perspective, he can ask you regarding the composition of glatiramer, and that would be the amino acids which are present in the myelin basic protein. So with the help of this drug, we're trying to promote the remyelination component by providing that raw material for myelin basic protein. This molecule that I'll be writing will be having a prefix L present before it. So it would be L-glutamic acid. Then apart from L-glutamic acid, present is lysine, the levoisomer, then is alanine, and then is tyrosine. So you just need to remember the amino acids which are mentioned for glatiramer: glutamic acid, lysine, then alanine and tyrosine, and they are the building blocks. It's a peptide copolymer of 4 amino acids. AA stands for amino acids. This peptide copolymer, the amino acids which are mentioned here, are the building blocks of myelin basic protein, and we are trying to provide the raw material for the remyelination in these patients along with injections of beta interferon. These drugs were previously the drug of choice. Now they'll be answered as only to be used in resource limited settings. Otherwise, he says ocrelizumab and natalizumab are the main drugs to be used. If he talks about secondary progressive multiple sclerosis and he's asking you to select one particular drug, then you'll be selecting S1P modulator. That would be siponimod in the patient, like I mentioned regarding fingolimod or ozanimod. Now mentioned regarding siponimod, which is a S1P modulator in secondary progressive multiple sclerosis. For primary progressive multiple sclerosis, I had mentioned right in the beginning, and I have mentioned it even in the middle as well, that in primary progressive, where the symptoms would be like progressing over more than 6 months or a year with no respite in between, we'll be using ocrelizumab. We need to be more aggressive. It's a variant or relapsing variety of multiple sclerosis, or bout onset multiple sclerosis, which has a, I would say, a relatively less aggressive course than primary progressive multiple sclerosis. As far as the clinical variants of multiple sclerosis are concerned, when I mentioned the term benign variety, in the benign variety, I mean, though MRI burden can be present of some lesions, but neurologically speaking, there would be no deterioration in a patient. Contrast this with what I say next, a Marburg variant. Marburg variant of multiple sclerosis has a very relentless course. Multiple sclerosis does not cause death. It mainly causes an increase in the morbidity of a patient. It makes the person become bedridden. It makes the person dependent on others. Person will be having problems with control of bladder, control with respect to control of passage of stool. So, I mean, the main problem with multiple sclerosis is the disability which is caused by it, and the person becoming dependent on others. It does not kill a person, but the Marburg variant can cause death within 1 to 2 years. As far as the clinical outcomes are concerned, we need to use drugs to reduce the attack rates. We need to reduce the disease severity and reduction in the new T2 lesions on an MRI. If the MCQ says what is the drug of choice to reduce the mean attack rate, or which drug causes a maximum change in the disease severity, then natalizumab is holding its position for, I would say, last couple of years. Though we have had newer drugs available, but natalizumab infusions on a monthly basis in JC negative patients, JC virus antibody negative patients will decrease the mean attack as well as reduce the disease severity. If he talks about which drug or which is the drug of choice which will help in preventing the development of new T2 lesions on an MRI brain, then this is a monoclonal antibody which I mentioned was available in subcutaneous injection and can be given self-administered by the patient. I mean, that is big deal, no? That you can give a molecule which a patient can take. Initial 3 dosages are given obviously in a hospital setting, but then as far as monoclonal antibodies are concerned, there are a lot of ifs and buts and precautions which are to be used, and they must be always given under supervision in the form of an infusion, and patient has to come to hospital again and again. I mean, half the time the dropout rate is not because of the cost of the drug. It's because the person has to come regularly for injections. So if we can provide something that can be given subcutaneously and the patient can self-administer, well, what better than that? So that is why ofatumumab is causing the max reduction in the severity. I mean, overall, I can say that natalizumab is the single best answer for reducing the severity or the burden of the disease. But if he specifically says new T2 lesions on MRI are reduced by, then you can check out in the table in Harrison as well that the efficacy is maximum for ofatumumab, contributing to as much as a 95% reduction. So these are the details that I would like you to remember for this topic. Keep the pressure on, keep hammering, keep on learning new things, and you'll become much more wiser. And I would like you at this point of time to listen to the next video. I mean, I know you're tired listening to me ranting about all these aspects, and especially the ENO part or the aspects of internuclear ophthalmoplegia that I spoke about, or then I talked about 1.5 syndrome. So it becomes tiring, I understand. But then if you just pump it up a little more and go through neuromyelitis optica spectrum disorder, then all this information will become much more organized for you, and you will be in a better position. Because what I've done in this next video, neuromyelitis optica, is compare the clinical manifestations of multiple sclerosis versus that of NMOSD, because ultimately in most questions they'll ask you comparison between these two demyelinating disorders, with the key word for neuromyelitis optica spectrum disorder being obviously presence of anti-aquaporin 4 antibody, which causes astrocytopathy. So these are the details. Thank you so much for hearing me out.